Hello, I am Dr. Anand Mamdani from the Department of Neurology. This is the fifth module in the series of Altered Mental Status. It focuses on management and prognosis of the patient in coma. This module has four objectives. After finishing this module, you should be able to describe emergent management of coma patient, describe various laboratory tests and other tests to be performed to determine etiology of coma, explain prognosis of various types of coma, and explain brain death. The initial clinical approach to the patient in a state of stupor or coma is based on principle that all alterations in arousal constitute acute life-threatening emergencies until vital functions such as blood pressure and oxygenations are stabilized. Potentially reversible causes of coma are treated, and the underlying cause of alteration in the arousal is understood. Considering that when patient is found in coma, the first thing we need to focus on is to stabilize the patient. If the airway is obstructed, remove the obstruction. Mainly if their Glasgow coma scale is 8 or less and they are not able to protect their airway, then patient needs intubation. After airway securement, we need to focus on breathing. If patient is having regular breathing and is able to maintain or protect their airway, then you can provide oxygenation if they are hypoxic. If patient's breathing is irregular and they are hypoxic, then patient needs ventilatory support. If we need to get an IV access to provide medications and IV fluids. If patient is hypotensive, then patient will need IV fluids or pressures to maintain their blood pressure to perfuse other organs of the body. Also, if patient is found unresponsive in unknown circumstances or a patient had trauma, then cervical spine precautions should be maintained. When patient is found in coma, to treat the most common causes, paramedics uses coma cocktail, which includes glucose, thiamine, and naloxone. Usually D50 with thiamine 100 mg IV is given. Thiamine should be given before glucose to decrease the risk of Wernicke-Korsakoff syndrome. Naloxone is an opioid antagonist and is used widely in coma cocktail. Flumazenil can also be added if benzodiazepine overdose is suspected, but don't give flumazenil in the patient who are on chronic benzodiazepine because it can cause benzodiazepine withdrawal and seizures. Lastly, we need to treat the underlying cause for the coma. Various laboratory studies can be performed to determine the cause of metabolic coma and to treat it. For example, basic metabolic panel or BMP includes sodium to determine hyponatremia or hypernatremia. You should always correct sodium slowly as rapid correction of hyponatremia can cause central pontine myelinolysis, or rapid correction of hypernatremia can cause cerebral edema. Both are causes for coma. BMP also includes BUN and creatinine to rule out uremia, which can be treated with dialysis. Calcium is also included in BMP to rule out hypocalcemia or hypercalcemia. To treat hypocalcemia, you can give IV calcium. Glucose is also being checked in BMP, which helps to rule out hypoglycemia or hyperglycemia. You can give IV dextrose or glucagon to treat hypoglycemia. For hyperglycemia, you can use insulin. BMP along with arterial blood gas can help with diagnosis of acidosis, metabolic or respiratory, as a cause for coma. Mostly to treat metabolic acidosis, you treat the cause. For respiratory acidosis, you can hyperventilate the patient to blow off carbon dioxide. ABG can also help to diagnose hypoxia. To treat hypoxia, you can provide oxygen. Liver function test, ammonia and coax help to diagnose hepatic encephalopathy. which can be treated with lactulose or dialysis. Complete blood count and lactate can help diagnose sepsis, which can be treated with IV fluids and antibiotics. Thyroid function test helps with diagnosis of myxedema coma, which can be treated with steroids and levothyroxine. It also helps to diagnose thyrotoxicosis. Cortisol level can be checked to help diagnose adrenal failure, which can be treated with steroids. You need to check thiamine in a patient who has history of alcoholism or looks malnourished to diagnose Wernicke's encephalopathy. We can also check serum osmolality if methanol or ethylene glycol toxicity is suspected. Salicylate levels and ABG can help with diagnosis of aspirin overdose. If patient is on anti-seizure medication, we can check anti-seizure medication levels. Every patient who has coma should undergo urine drug screen and serum tox screen, and also should have electrocardiogram to diagnose intoxication or ingestion. There are other tests that can be performed on special circumstances. For example, chest x-ray, blood culture and urine culture if sepsis is suspected, and patient should be started on antibiotics. Carboxyhemoglobin level should be checked if carbon monoxide poisoning is suspected. If meningitis or encephalitis is suspected as a cause of coma, lumbar puncture should be done. If a structural lesion is suspected as a cause of coma, like subarachnoid hemorrhage, intracerebral hemorrhage, or a mass lesion, then non-contrast CT scan of the head should be performed. If patient has impaired brainstem reflexes and stroke is suspected, CT angiography of head and neck should be performed. MRI brain also helps with diagnosis of structural, inflammatory, or autoimmune causes of coma. EEG should be done if seizures are suspected. Intracerebral pressure monitoring can be done especially in traumatic brain injury patient to rule out elevated intracranial pressure as a cause of coma. Outcome in a coma patient cannot be predicted with 100% accuracy unless patient is brain dead. The available evidence is not sufficient to permit a definitive statement that a particular non-brain dead patient will not recover from coma, nor does it allow prognostication regarding how much recovery may occur in specific cases. For prognostication purposes, coma is divided into three groups. Drug-induced coma are usually reversible unless patient had secondary brain injury because of hypoxia or hypotension. In non-traumatic coma patients, 15% make satisfactory recovery. A patient who has structural lesion like subarachnoid hemorrhage, the prognosis is worse. With hypoxic ischemic insult patient, the prognosis is better than subarachnoid hemorrhage patient. Patient with hepatic encephalopathy or other metabolic causes has better prognosis than hypoxic ischemic insult patients. Patients with traumatic coma usually have a better prognosis than non-traumatic coma, likely because traumatic coma patients are usually young and their initial neuroinsult doesn't correlate with their outcome. But many of the patients who survive traumatic coma may remain disabled at the long term. Persistent vegetative state can be reliably diagnosed 12 months after traumatic brain injury or 3 months after other cerebral insult. Patients with persistent vegetative state are less likely to have meaningful recovery. They have 5-year mortality greater than 80%, and most of them dies of infection or other complications related to persistent vegetative state. Miracle awakening is only seen rarely in minimally conscious state patients. Various neuroimaging can help with determining cognition as well as help with prognostication, but large-scale randomized controlled trials are lacking to approve this imaging as a standard for prognostication. The imaging studies that can be performed are diffusion tensor imaging, PET scan, functional MRI, and transcranial magnetic stimulation. Brain death is an important diagnosis for medico-legal purposes. If patient is in coma without any potential reversible causes of marked CNS depression like toxin or drug effects, sedation, paralysis, hypothermia, hypotension, hypoxia, electrolyte abnormalities, renal or liver failure, and brain imaging studies suggestive of irreversible cause of coma, brain death examination should be performed. The absence of arousal or absence of response to painful stimuli with absence of brainstem reflexes and no spontaneous respiration may suggest brain death. To confirm brain death, apnea testing should be performed. In apnea testing, patient will be removed of ventilator and watch for any spontaneous respiration while oxygenation can be provided through endotracheal tube. Arterial blood gas should be checked periodically. If PCO2 level goes above or equal to 60 or 20 points above baseline without spontaneous respiratory efforts, brain death is confirmed. If you are not able to perform apnea testing, other ancillary tests can be performed like electroencephalogram, suggesting electrocerebral silence, or conventional cerebral angiography, nuclear scan, transcranial Doppler, which shows absence of cerebral blood flow, are diagnostic of brain death. In summary, once the patient is diagnosed with coma, airway, breathing, and circulation should be optimized. Patient should be on C-spine precaution if found unresponsive under unknown circumstances or has trauma. Coma cocktail with glucose, thiamine, and naloxone should be given. Flumazenil can be given if benzodiazepine overdose is suspected. Various laboratory tests can be performed to diagnose and treat the underlying cause of coma. Other tests can be performed on special circumstances. Outcome of coma patient cannot be predicted 100% unless patient is brain dead. Drug-induced coma are usually reversible. Traumatic comas have a better outcome than non-traumatic coma. Persistent vegetative states are less likely to have meaningful recovery, and miracle awakening rarely happens in minimally conscious state patients. Various neuroimaging can be used to diagnose cognition and prognostication but lacks evidence. Brain death diagnosis is important for medico-legal purposes. In addition, I recommend these resources for further learning. Neurology in Clinical Practice, Chapter 5, Stupor and Coma, available as ebook at Roland Medical Library, as well as Disorder of Consciousness, Clinical Practice on Osmosis website.